afternoon, colleagues. My name is Anri Gerber. I'm a resident in internal medicine at the University of the Free State. That's in Bloemfontein, South Africa. Thank you for the opportunity to present my case report, Takayasu's arteritis, a clot or not. The outline of my talk is structured as follows. Please feel free to scan the QR code to get access to the poster. So, a small introduction. Takayasu's arteritis is a large vessel vasculitis that predominantly affects females of childbearing age. It's a chronic progressive disease that progresses through 3 stages, stage 1, 2, and 3. And the hallmark of this disease is vascular remodeling. It affects the aorta and its major branches, the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. The Numana classification is often used to classify which vessel is involved. There are 5 patterns of involvement as seen. In type A, it's the branches of the aortic arch. In type 2A, it's the ascending aorta, the aortic arch and its branches. 2B is the same as 2A with the thoracic descending aorta. And the third one would be the thoracic descending aorta, abdominal aorta, with or without renal artery involvement. Type 4, abdominal aorta with or without renal artery involvement. And then type 5 is the combination of 2B and number 3. So the case I'm reporting to you guys is a 34-year-old female that presented to our clinic with a confirmed diagnosis of Takayasu's arteritis. She had exertional dyspnea, orthopnea, and PND, as well as lower limb swelling. Her important clinical findings were as follows. Note, I'm only mentioning the important positive findings, not any negative ones. So she was tachypneic with a respiratory rate of 26 beats per minute, and she maintained normal saturations of 94%. She had conjunctival pallor and lower limb pitting edema. On cardiovascular examination, she had absent pulses of the right upper limb and features in keeping with pulmonary hypertension. She had an increased JVP, a left parasternal heave, a palpable P2, and a pansystolic murmur over the left sternal border, which increased in intensity on inspiration. Of note, she had a clear chest and an unremarkable abdominal examination with a non-tender enlarged liver. Her laboratory data on admission is shown. As you can see, she had features in keeping of a congestive hepatopathy with an ALT and an AST that was increased. Her pro-BNP was also increased. Her CRP was 22, and then she had clear features of iron deficiency anemia with an HP of 10.3, ferritin of 37, and a transferrin saturation of 5%. Her platelets for our reference range was also slightly low. So we started our investigations with a ECG, which showed us, which was actually normal. She didn't have a tachycardia, and then we referred her for a cardiac echo, which showed a right ventricular systolic pressure of 100 millimeters mercury with a severe tricuspid regurgitation and a normal LVF. Unfortunately, I don't have any images of the cardiac echo. After that, I proceeded to book her for a SPECT VQ scan, which is shown on these images that shows uniform distribution of the radiotracer throughout the right lung field on the ventilation and perfusion images, with uniform distribution of the tracer in the left lung field with absent perfusion. So we can all appreciate a unilateral whole lung ventilation perfusion mismatch. So there's further images that shows this. So then we proceeded to get a CT done, which showed a stenosis of the left common carotid artery and the left main pulmonary artery with a dilated right heart with contrast reflux into the IVC. There we can appreciate the stenosis of the left main pulmonary artery. I've asked our radiology department to do a CT reconstruction, which showed complete stenosis of the left main pulmonary artery, and we can all appreciate the small lung volume as seen on the recon images. So in essence, we diagnosed her with pulmonary hypertension, secondary to left pulmonary artery stenosis, complicated by right ventricular failure, with the precipitant being iron deficiency anemia. We commenced diuretic treatment. We gave her ACE inhibition in the form of enalapril 5 milligrams, and we continued the immunosuppression she was on at that time. We gave her iron therapy in the form of intravenous iron dextrin, followed by iron sulfate and supplements. She responded quite well to this, with resolution of her lower limb edema, as well as the resolution of the congestive hepatopathy that she had, with normalization of the hepatocellular enzymes. We're still working out for the iron deficiency, and endovascular intervention was not feasible due to the extent. So in essence, pulmonary artery involvement is variable. It affects up to a quarter of patients, few local descriptive studies, but not many case reports. Unexplained pulmonary hypertension can be evaluated by a SPECT VQ because it has a high sensitivity and specificity for detecting CTEPH, and it has a relatively low radiation exposure dose compared to CTPA. An acquired unilateral whole lung ventilation mismatch is rarely seen in acute or chronic pulmonary embolism. It's often seen in external compression of the pulmonary artery or in luminal narrowing of the arteries, as seen in vasculitides such as Takayasu's. It's very similar, the presentation, and sequential imaging can help us to determine what it is. So PE often resolves over time, and the Takayasu's prevail. Sorry, I'm a bit over time, but I need to finish if it's okay. So our conclusions was all patients with Takayasu's must be screened for pulmonary hypertension. The determining of the etiology is quite important because it may have treatment implications for patients. VQ scanning is often useful to rule out pulmonary embolism, and pulmonary artery involvement, although rare, should be considered as a differential for pulmonary hypertension in patients with Takayasu's. Thank you.
Well, thank you very much. We'll probably have some questions from our specialists. Let me take prerogative. I have this first. The VQ scan will show complete blockage of the lungs. It will not distinguish between stenosis and massive clot, would it?
So according to what I've read, it's not a unilateral obstruction is not often seen in PE because it's often segments that's involved. So that made us to do a CTPA, and that's when we got the left main pulmonary artery stenosis.
Professor Legault.
Me again, everybody. Thank you for your presentation. That's great. I just wanted to go back to, I mean, your title is clot or not, and I think that's what I'm still wondering about. The distinction in this case, I would find, would be very challenging between deciding whether this was progressive Takayasu's leading to stenosis versus thrombosis, and whether I send her to Dr. Duquetis up there to anticoagulate versus whether I'm going to intensify her TAC treatment, I would think would be the crux of the decision making at this point. But I see you left her on the same immunomodulatory regimen, so you did not think this was a TAC flare or progression of disease, and didn't think this required.
So we kept her on the same treatment because her ESR was normal and the CRP slightly elevated. So we didn't think it's a flare of the Takayasu. We think it was progressive of a chronic disease that she had. So we didn't think it was a flare.
Dr. Panju?
I must have missed it, but the association with iron deficiency anemia and the Takayasu's and the pulmonary stenosis, what is the connection? And what investigations so far have been, were you thinking of doing for iron deficiency anemia?
Okay, so in our setting, if we see iron deficiency, it's a female patient, we would think of bleeding, and females have predominantly 3 orifices where they can bleed from. So we started off with a pap smear and a gynae examination, which was normal, and then we referred her to the gastrointestinal unit for scopes, for colonoscopy and gastroscopy, even though there were not any features of bleeding that she reported to us. She had no melena stools or any stigmata of that, so still waiting for the results.
Go ahead.
So I have one question. This is a case of Takayasu arteritis with the involvement of the pulmonary artery. The systemic arch of aorta and other arteries was normal.
Sorry?
Arch of aorta and the branches, those were normal. Abdominal aorta.
So the abdominal aorta was normal. On the CT,
And arch of aorta,
on the CTPA, I can tell you she only had large vessel stenosis of the left common carotid, right common carotid, as well as the pulmonary artery. That's where the stenosis.
along with the arch of aorta, artery, pulmonary, both was normal.
Yeah.
Okay.
Okay, and the last question. Zora, no, stay. Oh, you
Thank
have
you.
one.
I was just surprised by the CBC, and you would expect perhaps increased platelets in the setting of that anemia. So did you have any prior blood tests before all this happened to see how her platelets were?
Unfortunately not.
Okay, all right, it just doesn't really match. Yeah.
Okay. Well, we have to finish. We have to have the next one.
Okay, thank you very much for this presentation.